Hello, thank you for joining the GW Cancer Institute for our webinar on Enhancing Cancer Program Partnerships with Area Health Education Centers. I am Aubrey Van Kirk-Villalobos, the new Director for Comprehensive Cancer Control at GW Cancer Institute. This webinar is our fourth in a series that will focus on providing technical assistance for comprehensive cancer control efforts. Before we get started, I'd like to take a few minutes to go over some housekeeping remarks. We ask everyone to keep their phones on mute to avoid any background noise and disruption during the program. Also, today's program is being recorded. We will use the question and answer feature for this webinar. You will see the Q&A box at the bottom right hand of your screen. If at any time during the presentation you have a question, please type it in and we will address it during the Q&A portion at the end of the webinar. The questions are anonymous and I will repeat each question to the group. We will take questions at the end of the presentation, but feel free to write questions in the Q&A box as we go along, and we'll make sure to answer them all during the time allotted. We will also use the chat box feature, which is on the top right-hand side of your screen. You can use the chat box to interact with each other. Because we will be talking during the presentation, we probably won't be able to keep up with the chat, so if you want to ask a question, please use the Q&A box on the bottom right. And as a note, before we get started, following this webinar, you will receive an email with today's presentation recording, a link to join Research to Reality for further discussion, and today's slides. The recording will also be archived on our website, along with our previous webinars. Now I'd like to take a moment to review today's agenda. I will first provide a brief overview of the GW Cancer Institute and our Technical Assistance Project. Our presenters will discuss partnering with AHECs to enhance cancer programs. Then we will conclude the webinar with a question and answer session, and we'll do so through the Q&A feature on the bottom right of your screen. We're very excited about today's webinar on cancer program partnerships with AHECs. Before we get started, I wanted to tell you a bit about the GW Cancer Institute and our new webinar series. The GW Cancer Institute was founded in 2003. Our vision is to set the standard for patient-centered care and eliminate cancer health disparities. And our mission is to ensure access to quality patient-centered care across the cancer continuum through community engagement, patient and family empowerment, healthcare professional education, policy advocacy, and collaborative multidisciplinary research. In September 2013, we were awarded a 5-year cooperative agreement from the CDC to provide technical assistance to enhance comprehensive cancer control efforts. This award is in addition to a separate award given to the American Cancer Society. We're working closely with them to coordinate activities to ensure we reduce overlap and duplication. Here you'll see the main activities we have planned for the 5-year project. We will leverage our online academy to build free online trainings for comp cancer programs. We're starting with our executive training on navigation and survivorship, and nuts and bolts training on creating and sustaining navigation and survivorship programs, as well as a competency-based patient navigation training. Each year we will add additional courses, and we started with 2 of our popular courses that historically have been given in person. Our breast cancer social media toolkit will be available very soon, distributed through our TAE newsletter. The toolkit will explain social media basics and provide ideas for engaging with followers on Twitter throughout the month of October. Other social media toolkits are in the works for the upcoming Cancer Awareness Month, so be sure to keep an eye out for them. Another key activity is our Ask the Expert series that will connect comprehensive cancer control practitioners with each other and with experts. We're building a database of experts right now to facilitate matching, and we just launched an online resource repository to facilitate sharing of best practices. We've also partnered with AHECs to host a total of 15 roundtables over the course of the 5-year project. The goal of the roundtables will be to discuss successes, challenges, and opportunities for strengthening cancer and chronic disease prevention integration efforts at the local level. You'll learn more about AHECs in today's webinar. We will also be providing large group and one-on-one TA. In response to your feedback, we're moving from a monthly to a quarterly webinar schedule. We will also continue to publish a monthly e-newsletter that aggregates technical assistance opportunities. Currently, we're doing one-on-one TA by request. Finally, we're creating a tool to help comp cancer programs align local initiatives with national priority health indicators. We're working to provide all of these technical assistance opportunities and have many more planned. If you have suggestions for topic areas for webinars, resource guides, or are in need of other forms of technical assistance, please email us at cancercontrol@gwu.edu. Here's some information about the Cancer Institute's technical assistance resources. We recently launched our new Cancer Control Technical Assistance portal. You can visit www.cancercontroltap.org to visit the site, which includes the resource repository that I mentioned, where users can search for and access comp cancer resources produced not only by GW, but also by state comprehensive cancer control programs and their partners, cancer control coalitions, and other stakeholders. You can also subscribe to receive our monthly e-newsletter on Cancer Control Tap. We encourage you to check out our free Cancer Survivorship e-learning series for primary care providers at the link on the screen. That's cancersurvivorshipcentereducation.org. Following this webinar, you will receive an email with the recording and today's slides. You'll be automatically redirected to an evaluation survey to provide feedback on today's webinar at the conclusion of the presentation. Now, I would like to introduce you to today's presenters. Robert Trachtenberg has been the Executive Director of the National AHEC organization since October 2010. Before that, he was the Associate Director of the statewide Rhode Island AHEC program and a teaching associate in family medicine at the Albert Medical School of Brown University from 2005 to 2011, as well as the Executive Director for the Champlain Valley AHEC in rural northwestern Vermont from 2000 to 2005. He has more than 18 years of experience in organizational development and the leadership of community-based organizations. Mary Craig is president of the Erie Niagara AHEC in Buffalo, New York, an instructor in HIV/AIDS for teachers, a health leadership fellow with the Community Health Foundation, and a National Health Service Corps ambassador. She is a board member of NAO and currently chair of the Center Directors Constituency Group and co-chair of the Education Committee. Ms. Craig is a certified cultural diversity and sensitivity facilitator with significant training and experience in building cultural competence and examining its impact on health attitudes and health outcomes. Ansley Mora is charged with implementing community health worker training programs, coordinating tobacco training for health professions students, facilitating development activities, and assisting with the marketing and public relations efforts for Gulf Coast South AHEC. She has worked in the nonprofit sector for more than 20 years and has been employed with Gulf Coast South AHEC for 12. Her past experience includes providing vocational and health and human services to underserved populations and launching a management assistance program offering education, tools, and resources to local nonprofit organizations. Finally, and certainly not least, Sharia Thompson Robinson brings over 15 years of higher education and outreach experience on both Capitol Hill and in a variety of frontline roles. Since 2009, her unique insight into public-private partnership development has expanded the Capital City AHEC Center office services throughout the national capital area. Ms. Robinson currently serves on a number of D.C. community advisory boards, including the D.C. Health Benefit Exchange, District of Columbia Tobacco-Free Coalition, and GW Cancer Institute's Comprehensive Cancer Control Technical Assistance Advisory Committee. Now I'll turn it over to you, Robert.
Great, great. Well, thank you. Thank you. I hope everyone can hear me. Please let me know if you can't. It's really a pleasure to be here to talk with you this afternoon, and thank you for giving us the time to talk about the AHEC program and the National AHEC organization. We really are in the throes of a very nice relationship and partnership with the George Washington University Cancer Institute, and very pleased to be here along with my colleagues who are there, as you just were introduced. And here's their contact information, and we certainly can come back to that later in the presentation if you would like that. So this afternoon and through the course of the presentation, some of the objectives that we would like to leave you with are providing an overview of the HRSA Bureau of Health Workforce, where the AHEC program is situated, and that's new. The Bureau of Health Workforce is fairly new, and I'll talk about that in a moment. I'll talk about broadly and federally the Area Health Education Center program, at least as HRSA defines it. And then we'll get into, and probably here is where we'll spend the brunt of our time, or my time certainly, describing the National AHEC organization and some of the key partnerships that we have, some of the activities that we have, and the work that we do on behalf of our AHECs. The National AHEC organization is the member organization, the member association of AHECs all throughout the country. I'll then at that point turn it over to my colleagues who will summarize some of their recent NAO and AHEC Cancer Coalition activities. And then at the end, we'll be able to spend some time to discuss opportunities for future and further collaboration, as well as answer any questions you may have. In terms of the HRSA Bureau of Health Workforce, perhaps you're familiar with this or perhaps not. The Bureau of Health Workforce programs, according to HRSA, this is straight from their website, help America build a healthcare workforce prepared and eager to improve the public health by expanding access to quality health services and working to achieve health equity. All the AHECs around the country, in some capacity, do work as related to the main objective and goal of the Bureau of Health Workforce. We'll drill down a little bit further in just a bit to talk about those activities that AHECs do as it relates to the Bureau of Health Workforce. You may also know that the Bureau of Health Workforce was recently created just a few months ago, which integrated two previously similarly missioned bureaus, the Health Professions Workforce, the Health Professions Bureau rather, where the AHEC program along with many others were situated, and the Bureau of Clinician Recruitment and Service, which historically oversaw the activities of the National Health Service Corps. AHECs all throughout the country, in I'm sure more than 100 AHECs have participated in the past as National Health Service Corps ambassadors, and certainly Mary Craig on the phone today is an ambassador. I myself am an ambassador. And through a restructuring, these two bureaus became one, and now it's the Bureau of Health Workforce. And there's still some I think strategically it makes a lot of sense. Certainly the AHEC program is there as part of the Bureau of Health Workforce. And there's some transition certainly, but I think this new system and this new structure works quite well. And then the AHEC program is way down in the Division of Health Careers and Financial Support and within the Health Careers Pipeline branch. Historically, the AHEC branch was its own branch, but now the AHEC is partnered with the Health Career Opportunity Program and the Centers of Excellence. And I'll touch briefly on each of the AHECs and the COE. The purpose of the Health Careers Opportunity Program is to increase the number of individuals from educationally or economically disadvantaged backgrounds who enter the health and allied health professions programs. And then the purpose of the Centers of Excellence, the Center of Excellence is a grant program designed to assist eligible health professions schools to support education and training enhancement programs to increase opportunities for underrepresented minority individuals to enter and successfully complete a health professions academic program. AHECs work very closely with the HCOP program, work very closely with Centers of Excellence, and it seems to only make sense that now the AHEC program is joined together with these other two programs under the Health Careers Pipeline branch. The AHEC program itself really began in the early 1970s as a result of a Carnegie report to Congress, the Higher Education Report and the Nation's Health Policies for Medical and Dental Education, which really looked at healthcare availability and delivery in the United States, particularly in rural, underserved, low-income communities all throughout the country. And the AHEC program really began as a result of that when in 1971, Congress first appropriated funds to develop the AHEC program as part of a national strategy to improve that supply, the distribution, retention, and quality of primary care in those medically underserved areas. And at that point, it was primarily rural. As you'll see over the years, we've moved into frontier areas in the United States as well as urban underserved areas too. But really the AHEC program started as a result of that Carnegie report that indicated that access to care was quite inadequate in those rural underserved areas in the 1970s. As defined by HRSA, the AHEC program enhances access to high-quality, culturally competent health care through community-based, interprofessional, interdisciplinary training, continuing education, healthcare's outreach activities that will ultimately improve the distribution, diversity, and supply of the primary care health professions workforce who serve in those rural and underserved healthcare delivery sites. We winnow that down to something a little bit more catchy, I think, sort of grab them, train them, keep them. That's really what we believe we do. We recruit folks into the health professions workforce. We try to keep them there and move them along a pipeline of educational experiences, experiential activities, so that after they move through their training, the likelihood that those health professionals will return to those underserved communities and work, establish their careers in those underserved areas, and stay. And we have strategies for each of the grab them, keep them, train them components of that pipeline. So we work all along the continuum of the health professions workforce pipeline. The initial cohort of the AHEC program was 11 states, and it's since grown nationally on that state-by-state basis to our current 45 federally recognized states, and that's important. The federal designation is important, and I'll talk about that in just a second as well. Over those 40 years or so, 43 years now, since 1971, states have somewhat come on, stayed, some have left, and then only later at another grant opportunity returned into the AHEC program. And what typically occurs is that a coalition or collaborative group in a particular state will come together, realize that there's a role for the AHEC program, and apply usually 2 or 3 times to HRSA to get an AHEC program authorized. And what typically happens is, and this is what happened in Rhode Island when I started at the medical school at Brown University in 2005, there were 2 or 3 attempts at getting an AHEC program. One wasn't funded, one was awarded yet not funded, and then the third try, the AHEC program was awarded to the state. And in a minute I'll talk a little bit about where those AHECs are housed and located, but it really takes some key people at the state level to identify the need and then put together a proposal. The AHEC program is authorized and gets an annual appropriation by Congress. Our authorization occurred, our reauthorization occurred in 2010, actually as part of the Affordable Care Act, and we have an annual authorized appropriation for supporting our entire network of $125 million per year. Usually we're kind of around the $30 million annual appropriation each year for the AHEC program, and have to work very hard to get that as well. However, over the course of the large national scale AHECs that we have, that authorization and the appropriation of that $30 million or so leverages about $250 million of other community-based resources, either a legislative appropriation from a state, foundation dollars, fee-for-service activities, grants. I'm sure many of you do very similar activities in terms of getting resources into the programs that you run. So every year we have to fight for our appropriation. It's something that we spend quite a deal of time doing. In terms of NAO, the National AHEC Organization is the membership association that essentially is there to support the AHEC network. And our mission is to improve health by leading the nation in the recruitment, training, and retention of that diverse health workforce for underserved communities. NAO as an entity came on in 1999 and was primarily staffed by all volunteer people who led either AHECs at an academic health science center or in a community-based center. And again, I'll talk about the numbers on that in just a moment. Our first staff member came on in 2010. That was me. And we're growing ever so slowly. But that national association is there to support the work of the AHEC network. And that's really how we got connected through the George Washington University Cancer Institute, along with Shairia, who's on the call too, who will talk about some of the work that she's done with GW prior to us connecting at the organizational level. The AHEC vision, the NAO vision, is that the AHEC network will be the national leader in developing that highly competent and diverse healthcare workforce for underserved populations. The way it looks here is that medical schools have to be the recipient of the AHEC program, and certainly that was the case prior to 2007. After 2007, nursing schools were eligible to get an AHEC program. The way we're currently structured as of today is that there are 55 medical school AHEC programs. 52 of those are allopathic, and there are 3 osteopathic medical schools that have an AHEC program. The medical school is considered the awardee or grant recipient. Those osteopathic schools are A.T. Still in Missouri, Nova Southeast in Florida, and the University of New England in Maine. And as of 2007, those AHECs, the nursing school AHECs, were eligible to apply for AHEC dollars, and there are 2 nursing schools, one each in Montana and Alaska, that house an AHEC program. The way the AHEC program is structured and the way the funds roll out is that the Academic Health Science Center is the grantee or awardee, and we develop these community-based centers. So over the many years since the AHEC program was established in the early 1970s, we've since grown to 248 community-based centers. 66 are 501c3, 66% are 501c3 nonprofit organizations governed by a community-based board. 29% of those are hosted either in a community health center, a Department of Public Health, another non-medical school academic health science center, or some other consortia. And then 5%, which are very few, are part of some other model. But essentially, what's very important and statutorily required, which bumps me down to the very bottom rectangle, is that the federal 75-25% rule has to be in play. And that means for every dollar that flows in via the federal funds to support the AHEC program to an academic health science center, 75 cents of every dollar has to flow out to the community-based centers. And that's the way that the resources flow from the academic health science center out to those community-based organizations. And that's sort of a sacrosanct policy. Over time, we've grown to the 45 states that have an AHEC program, including the District of Columbia, and then 2 territories. So that particular piece of information is a little confusing because there are AHECs in Kansas, Missouri, and Oklahoma that do have AHECs, but they're not federally recognized, meaning that at one point there was an academic health science center that supported the AHEC program, was a grantee, and either opted out or went through some type of transition, yet the centers, those community-based organizations, were able to stay on. So truly we have AHECs in 48 states, but only 45 are federally recognized. At this point, Iowa does not have an AHEC program in any capacity. It previously did, and Delaware never has. I don't know why. They've never applied or have expressed, or any leaders within the state have ever expressed interest in pursuing an AHEC grant. So there are 45 federally recognized AHEC states with those 55 medical schools and 2 nursing schools. So some states have more than one award. Yet there are AHECs in those states that don't receive federal dollars but still consider themselves AHECs and are members of the National AHEC Organization. In doing a very recent study, we looked at what our reach is within the context of our 248 community-based centers, and we found that we touch somehow, in some way, about 2,700 of those counties in the United States. Well, there are only 3,100 counties or county equivalents in the United States, so we really connect to nearly 85% of all the country, including places like Guam, the Republic of Palau, and Micronesia, and American Samoa. Our year essentially starts on September 1st, and we just learned, in fact, that there will be an expansion of 16 AHECs in 8 different states starting right now. So that reach will even continue. And we will see new AHECs in Colorado, Arkansas, Alabama, Ohio, Michigan, Illinois, Nevada, and Montana, which increases our reach into rural, underserved, urban underserved, and frontier underserved communities. So we're very, very happy about that. This is a very broad-based range of AHEC activities. Not every AHEC, which range in size from 3.5 or 4 FTEs up to, in some cases, 200 FTEs in places like North Carolina, do all these types of activities. But certainly focusing continuing education and continuing medical education, community health education, and the development of community health workers are part of many, many AHECs. The evaluation and training technical assistance piece is very much part of our integrated AHEC program, and in fact, we are wrapping up a 5-year project with HRSA that looked at evaluation, performance enhancement that we call the AHEC program, and that can be found on the HRSA website also. Most of the bread and butter type activities that AHECs do in terms of the workforce pipeline are K through 16. There's myriad activities that those AHECs do to recruit students into healthcare pipeline. Many of the AHECs, not just at the program office level, which is where the program office is the word we use to describe the academic health science centers, and the community-based AHECs are considered centers. So program is medical and nursing schools, centers are those community-based organizations. Each of the AHECs, as a grantee awardee, must do a health career workforce needs and data analysis to look at projections of what the workforce looks like, what it could look like, who's retiring, and that's quite a bit of work. But as we work to align workforce needs with what's out there, this is one way of providing data to congressional members, to state folks at the Department of Health and doing planning, and it's very much a key component of AHEC activity. The National Coordinating Center for Interprofessional Education and Practice was awarded to the Minnesota AHEC just a few years ago, and that's another 5-year project that will focus significantly on IPE and IPP, and that's very much taking off and growing within the context of our AHECs around the country. Minority health and diversity is another component of AHEC activities, working to get those health profession students who are underrepresented, minorities, into health professions training programs is a key component of our activities throughout the country. It makes sense, again, that we're aligned then with the HCOP program and the Centers of Excellence, and we have a number of activities where the HCOP and the Centers of Excellence and the AHEC programs all overlap. And then certainly primary care training as we work to enhance the primary care workforce. That's another sort of bread and butter activity. And more we're looking at the primary care behavioral health integration component too, as we work, a few AHECs throughout the country are working on more mental health type activities. The Youth Mental Health First Aid activity, an initiative out of Connecticut right now, and a variety of AHECs around the country are looking at the primary care behavioral health integration component too. Service learning, tobacco cessation, veterans mental health, all other activities that the AHECs are engaged in. And I'll talk a little bit more about the veterans mental health piece in just a second as we talk a little bit more about some of the key partnership organizations that we are engaged in. So very briefly, sort of AHEC by the numbers, on an annual basis we provide over 1.5 million continuing education contact hours. Throughout the national network, we have over 12,000 community-based training sites. We introduce over 400,000 students to health careers annually, and then you can see the number of health professions that are provided continuing education. We have key partnerships with 600 plus non-medical health science centers and other academic institutions where we're providing student experiences, providing support, providing outreach, education, community-based education in a variety of ways. And then federally, we have partnerships with HRSA and SAMHSA and Department of Labor, and those continue to evolve over the, as NAO continues to grow, we are engaged with the federal funding agencies a little bit more. The SAMHSA piece was particularly focused on our veterans mental health piece, which again, I'll talk about that in a second. Additionally, we have partnerships with about 1,100 community health centers, and those partnerships can be a whole variety, or can take on a whole variety of functions and activities, including, as I mentioned, being hosted in a community health center. 11 of the 15 AHECs in California, for instance, are embedded and integrated into a community health center. Other ways that AHECs support and work with community health centers are through providing community education or providing an experience for health profession students to cycle through and see what it's like to work in a community health center. As a center director in Vermont many years ago, I had a medical librarian on staff, and she worked primarily at the community health center, which was probably 30 or 40 miles away from my AHEC, and she was responsible for providing continuing education and resources to the providers at that community center, the community health center, and it seemed to work very well. So AHECs throughout the country have a wide variety of partnerships with community health centers. And, you know, one of the things as I talk about our partners and what our network looks like, that phrase, the key strength of the AHEC network is its ability to creatively adapt national initiatives to help address local and regional healthcare issues, came from Mandy Chapman at GW. And this, you know, Mandy, if you are listening, if you're on, thank you for that phrasing, because it so eloquently and adequately captures what we're trying to do with our AHEC network. And so we've co-opted it entirely and are using it to highlight what our AHEC network is capable of. And these bullet points here are just a few of the items, a few of the initiatives that, from an NAO perspective, NAO is working to utilize the AHEC network to tackle some of these large-scale issues. So, for instance, we have some funding from the Amgen Foundation to do national-scale CHW development. We just wrapped up a smoking cessation initiative through the CS Today group. Of course, we're working with the Cancer Institute. We're also working with the George Washington Department of Health Policy on our Marketplace project, and that is a customized state-by-state template that we're providing to AHECs, who are then in turn training providers on what their particular state looks like as it relates to the Affordable Care Act, Medicaid expansion, and what the insurance marketplace might look like in a particular state. And that project's concluding as well, but that's been extraordinarily successful thus far. I mentioned our HRSA ATRAC program before, and that's the evaluation and technical assistance. We've worked with the France Foundation to provide resources to AHECs in Oklahoma, Texas, and Nebraska to work on patient vaccination initiatives. We recently wrapped up another initiative with the Interstate Postgraduate Medical Association on the REMS opioid mitigation strategy, and we had about 40 AHECs who participated in community-based training regarding the opioid prescribing issue that's currently facing many states right now. A new one for us is working with the American College of Rheumatology and the Lupus Initiative, as well as previously working with NHSC on the Collegiate Health Service Corps Expansion Program, which was a pilot program that introduced sort of first-generation college students to health professions careers and provided an enormous amount of support for those students as they moved through their academic training onto a career in healthcare. Again, the SAMHSA piece on the behavioral health, and then we're engaged with the VA a little bit in terms of providing training to both VA-based and non-VA-based providers who are seeing returning veterans from previously Iraq, now likely Afghanistan, on post-traumatic stress and other behavioral health and substance abuse issues. So we use our AHEC network to reach into those communities in ways that few other organizations can, as far as I can tell, to do provider-based training on some of these key national initiatives that are very important. And now I'll turn it over to Ainsley, unless there are any questions, and she'll talk about the Gulf Coast South AHEC and some of the work that they're doing.
Good afternoon. My name is Ainsley Mora, and I work with Gulf Coast South AHEC. We cover Manatee, Sarasota, Charlotte, and DeSoto counties in the central west coast area of Florida. And when I was asked to contribute some slides for this presentation, I was really focusing on the work that we're doing and have been doing with the cancer collaboratives locally. But when I look at what my colleagues added, they also talked about the work that they're doing around cancer care. So I wanted to include that as well. The regional collaborative, the regional cancer collaborative that the 4 counties that we serve are a part of is called the Southwest Florida Cancer Control Collaborative, and it covers 16 counties in Florida. We were approached in 2010 by this group to participate in some continuing education, to actually offer some continuing education programs to try to drum up interest and participation in the collaborative, and it was a really strategic way to get people involved in the collaborative once again. The reason why we were approached is because we've had years and years of experience of doing continuing education programs for nursing and mental health professionals and other healthcare providers. So we have done a lot of cancer-related CE programs, but I think mostly was our work around community health workers. And I was hired by Gulf Coast South AHEC in 2002 to start a community health worker training program. And initially we worked on cardiovascular disease for a couple of years, and then we really just started partnering with all of these cancer-related organizations. So one of our longest and strongest partners has been Susan G. Komen for the Cure. We work with a Suncoast affiliate and do programs in 2 of our counties. We've worked with them since 2006 in various forms. We also work with the American Cancer Society Florida Division. They funded us for 3 or 4 years. We've been partnering with them since 2010. And on a national level, I found a grant opportunity for Prevent Cancer Foundation, and we were funded for a community health worker program in 2010. And last but not least was the Florida Breast Cancer Foundation has funded our community health worker programming in Charlotte County currently this year. I'm actually doing the training this Saturday for a group of community health workers in Port Charlotte. So through that work that we've done, cancer-related, of course you're asked to participate in different stakeholder meetings and different activities. And what we found is that we were acting as somewhat of an informal coordinator for cancer care stakeholders. And the idea of coming from that is I wanted to prepare our community health workers as much as possible. So I wanted them to meet the local cancer service providers so they would have a way to refer to them easily. So then through that work, we've just been able to build partnerships and sustain those partnerships. And like I said, and like the slide mentions, that we were approached by the Southwest Cancer Control Collaborative in 2010. We did some continuing education programming, and then I have remained involved with them throughout that time. And the group, again, is gaining some traction. They recently underwent a strategic planning process, and they established some goals that I have listed on the PowerPoint presentation. So it's exciting to see, to kind of have been with the collaborative, in one stage, and then in many groups there sometimes are lulls, but now there's traction and things are moving forward once again. The goals that were established through the strategic planning process were to recruit and maintain active membership of at least 16 people, to develop a communications plan and form a communication committee so we can continue to gain new members and keep our members active. And 3 more goals that were established were to showcase at least one statewide or member prevention effort at collaborative meetings so we could all learn about the resources that are available and feel like our voices have been heard and establish connections through that showcase. Another goal is to facilitate annual patient access and navigation networking meeting with the collaborative and its partners. So that's another initiative that's being worked on. And establishing and maintaining a survivorship work group and promoting at least 2 survivorship-related activities. So these are the current goals of the Southwest Cancer Control Collaborative. And as a representative of Gulf Coast South AHEC, I will continue to be involved with the group. We do meet quarterly, and there's other activities that we will participate in. I did want to mention a neat program that is really related to our core AHEC work, and that is we actually, through our participation with the Southwest Cancer Control Collaborative, I saw a grant RFP for Sea Change, and they were doing a specific program on how to build interest in cancer careers. And so what we did, I worked with our student programs coordinator, and we developed a comprehensive program where we basically folded in the oncology careers into our youth pipeline programs, and it worked out wonderfully. And that program is called Comprehensive Cancer Careers Program, C3P, and we did it for about 1.5 years, and we still keep the information in our health careers presentation about cancer careers, and it just was one more collaborative piece that we were able to do in the cancer field. That's about all I needed to cover. I'm going to pass this on to our colleague Shirea Thompson-Robinson with Capital City AHEC. Thank you.
Thank you, Ansley. And Rob and Mandy as well. I'm very excited today to be on the call to talk about Capital City AHEC. We actually started in 1999, and we are here in the nation's capital, and we partner with the GW Cancer Institute. When we started in 1999, one of the things that we became a leader in was community health work, training and development, and patient navigation as well. And actually, Dr. Lisa Alexander, she is the Assistant Dean for Community Partnerships at GW, partnered with Mandy and Dr. Steve Paterno, who used to be with the Cancer Institute, on many initiatives. And this is how we actually got the link with the AHEC program. So thank you for mentioning me, Rob, but Lisa and I know Mandy had worked on bringing this to the national AHEC level, and we're excited today to share some of the things that were our best practices and some of the programs that we thought, again, would be exemplary for other AHECs to actually replicate with the GW Cancer Institute. So as I mentioned, we are a national AHEC. We serve on local and national initiatives. And one of the interesting things that we found, because our population is vulnerable, is that many of our patients have comorbidities and challenges with access to care. So to navigate a patient in DC, you've got to take on all three, not just cancer. And so what we found, we reached out to our partners, and GW has been a long-term partner, and we were excited for the technical assistance opportunity to join that steering committee. We also were asked by the Cancer Institute to participate in a national initiative to really define what is patient navigation and what's the framework in that role delineation. In addition to that, we also just wrapped up our AHEC Marketplace initiative, and again, that's to link and educate providers on Affordable Care Act services, enrollment, and get them up to speed to really be able to provide that education and the resources to their patients. And we also here in DC are funded as actually the top DC HealthLink ACA in-person assistor organization. We just got another opportunity to extend to year 3 for that. And then we recently had an opportunity through our Komen partnership to work with the Center for Disease Control Advisory Committee on Breast Cancer in Young Women. Congresswoman Debbie Wasserman Schultz has become an honorary DC Pink Diva and really has become an advocate for the women in our program. And we recently were invited to work on her next form of legislation for the Early Act. So sometimes I think as an AHEC location is important, and other times it might be your background. I'm a former Hill staffer, and we really fold in advocacy opportunities for our ladies. And in this instance, we were just honored to have an opportunity to now shape the legislation for the women we serve. So I'll move on to the DC Pink Divas. The DC Pink Divas was actually born out of initiative with GW Cancer Institute. It started as the Citywide Patient Navigation Network. We were proud to join this initiative. We provided resources for the call center, ran the call center, and a wiki resource for the navigators. And what we found is that while the navigation services really did make an impact in our community, our navigation team really noticed that there were women that needed more education and resources, as we say, where they live, work, play, and pray. And so we wrote what we call our dream grant to Komen to actually close the gap in Ward 7 and 8. Unfortunately, in the country, there's lots of things DC has to be proud of, but unfortunately, we are #1 for breast cancer mortality rates. And so we wanted to actually change that with the women we were serving as navigators, but to empower them. And so DC Pink Divas is a lay health worker training program, and that's actually a diva. So the divas are women that are trained in a year training program. And then the navigators are the navigators that, again, we started with the Cancer Institute project, provides that training and navigation support for women that they refer for services. And then the outreach component, we serve our community. So the lay world health workers work in their own trusted networks. If you're a beautician, you might be educating someone in your salon. If you're a church health minister, you may be educating someone in your church. If you happen to run a communications firm, you may be helping us with our social media leg. We really meet women where they are, and we want to give them the tools to help them tap their network. That's really how we've seen in vulnerable populations, especially with African American women, getting that trusted message in their network has made a huge difference. So for us, as I said, we empower, educate, and impact women, and we also work with girls. We found that using one of our pipeline programs called Kids to Health Careers, we have annual funding from the Campaign for Tobacco-Free Kids. And we're already educating young girls on tobacco cessation, on positive image, health, and we found that these girls were interested in working with the divas, and so they became DC divas, and we actually have overlap where we've got some mothers that are DC Pink Divas and some students that are DC Divas, where they really have grown to share information. They create public health campaigns each summer to educate people in their community based on methods that work for them. So it might be a YouTube clip, or it may be a PSA, and then we use that to educate our community as well. And so we were honored when we were funded by Komen. As I said, for our DREAM grant, we got our first initial $200,000 to really start the Lay Health Worker Initiative. We started in Ward 7, and we quickly went back and said, the evidence is showing we need to be in 8, and so forth and so on. We expanded from all of D.C. into Maryland, which, if you know the area, PG is considered Ward 8. Ward 9 of D.C. There's 8 wards in D.C. It's very porous because of gentrification. And then we moved into Northern Virginia. So because of our impact, we actually were invited in 2014, this year, by Komen to become a special grantee. So this is a wonderful opportunity for a long-standing partnership with Komen to really develop the program, not just here in the Capitol, but to expand it nationally. In 2 years, we were able to provide annually 300 direct navigation services, and that's from outreach all the way from suspicious legion to survivorship. And so that's 600 women every 2 years. We also provide 300 mammograms every 2 years to women, screening and diagnostic. And then we also provide over 3,000 resources to women, whether it be transportation, which is the #1 barrier, or it might be smoking cessation resources. One of the other things that we're proud to say is, as I mentioned, we were able to receive recognition for the work that we've done, and we were honored to learn that we are the leading cancer navigation program in the country. And I think it's really because of the strong partnerships we've been able to develop. We pride ourselves on talking about not just having a program and what we say cutting and running in the community. We make an investment, and if something seems as if it's not sustainable, we really find those innovative partnerships to make an impact and sustain those relationships. And so our Divas program is very proud of that. This October, it's on newsstands. We'll be featured in O Magazine. And we were just invited to work on a national disparities initiative with the Redskins. The NFL just issued a new campaign called Crucial Catch with other player associations and teams throughout the league. And we are working on that to really make sure that people are just not aware, but actually getting connected to services. We also are working with the Triple Negative Foundation, which, again, for African American women, it affects us more. And we have been working with local partners, as I mentioned, the GW Cancer Institute. We also work with Breast Care for Washington, who is housed actually in a community health center that partners with Community of Hope. And they are a partner for our clinical rotation program. So clinical interprofessional education as an AHEC, as Rob highlighted, is another area that we do. I like to say there's no arm of AHEC that we won't overlap to really create an innovative partnership to provide the best services for our patients. And so we were able to expand that partnership. We also have been a longstanding partner with the DC Department of Health Cancer Control Program, Project WISH, and DC Primary Care Bureau. We used to have a cancer consortium here, and it's kind of dissolved, but for years we were part of that as well. We also found a very unique partnership opportunity with the Washington Hospital Center Religious Traditions Initiative. Most women in our community make a lot of their choices based off of their faith-based influence, and this has been an invaluable partnership. We've been able to reach over 5,000 women just from that one partner alone, with over 250 congregation memberships, synagogues, and churches, and mosques. And then we also partner with the DC Tobacco Free Coalition, DC Primary Care Association, American Cancer Society. I already had mentioned the Redskins. We are looking at one with the Baltimore Ravens to really just make sure we're reaching people. Again, that's a play place, live, work, play, and pray. And then nationally, there's an initiative called Sisters Network. There's 2 chapters here that we've been able to work with a lot of survivors to activate them. And then Sisters Informing Sisters are another one of our partners. And one of the unique things I will say in closing is that from our experience as navigators, we found early on that a skill is a skill is a skill. And when we perfected our navigation practice, we were afforded opportunities to really look at those comorbidities. So we've been funded to work on a PCORI project for diabetes navigation and screening. We were afforded another opportunity to submit an application. We were just invited to PCORI for a very similar sister-to-sister navigation project here in D.C., Maryland, and Virginia as well. So that's how we've kind of expanded our practice. Feel free to ask us any questions. Thank you for your time.
Hi, this is Mary Craig, and I think I'm the last. I'll try to make this as brief as possible so that we can have some time for questions. I'm the president of the Erie Niagara AHEC. We've been providing community health education to underserved residents in Western New York for about 10 years now. Recently, we became a member of the New York State Cancer Consortium, which is a consortium I'm very familiar with because in my previous life, I was vice president of advocacy for the American Heart Association. So we work very carefully in that coalition for tobacco control. And as a result of that, I'm very pleased to say that the tax on cigarettes in New York State is the highest in the country at $4.35. So that's an ongoing effort that I'm very proud to be a partner with. We are partnering with the Community Health Center of Buffalo, which is also where we're housed as of lately, recently to develop a health education series for cancer wellness, awareness, and prevention, which is a particular passion of ours because as a minority health person in this area that's a member of a lot of different coalitions, and especially since we like to let people know that we're sort of the neutral convener and facilitator of a lot of the meetings that we go to. And that's because as an AHEC, we don't have to have that strong allegiance to, unfortunately, one chronic disease. And the fact of the matter is, if you're going to talk about recruiting people who are underserved into health careers, you have to, at least in our opinion, develop health education for all chronic diseases, especially to the population where our students are coming from. The two really work hand in hand. So as another opportunity, we see, and the reason why we wanted to become a member of this is because we see it as an opportunity to really reach out into our community, to look at how we can help our underserved community do things like develop community forums, to involve residents in the discussion about cancer, especially here at the Healthcare Center. Our objective is to develop a community design communication tool, and then a young adult network. Because one of the things we've learned as an AHEC is young adults, young people have not only a strong responsibility because a lot of them act as the chief communicator and caregivers of their families. So increasing their awareness of facts will help them identify resources and use those resources that we're going to help them identify rather. And hopefully increase the number of practitioners we have because we've started them at a very early age. So I've done a very brief presentation, but I hope that gives you a really good idea of what AHECs are capable of doing. So with 5 minutes left, Rob, I think I'm going to turn it back over to you.
Okay, thank you so much, Mary, Robert, Ansley, and Sharia. We really appreciate you sharing your expertise today. I'm cognizant of the time. I know we've only got about 5 minutes left in our hour window, so I will open the question and answer up. If anyone has a question that they want to ask, please go ahead and type it into the question and answer area now. While we're waiting for people to submit questions, if they have some, I've just got sort of a general question. I feel like I learned an awful lot today being new here at the Cancer Institute. And so my first question is, how would a local cancer program or coalition go about reaching out to their state or local AHEC, and how would you recommend that they start to build those relationships and collaborations? And that's open to any of you who've built such great collaborations that you talked about today.
Great. Thanks. That's a great question. This is Rob. I'll take that from a high-level perspective, and then Mary, Ainsley, or Sharia can jump in on the local piece. But certainly going to our website is a great place to start, as there's a list of all the academic health science centers that have AHEC programs, as well as all the community-based centers, and they're organized by state. So simply going to nationalahec.org, you should be able to get that information. There's a lot of receptivity to people reaching out and being connected to continue to do the work that is necessary in local communities. And starting with the website, I would recommend as the best place. And Mary or Ainsley, Sharia, any other comments to add?
You know, Rob, one of the things I think because we're out in our community an awful lot is to just pick up the phone and call or email us. I still answer my phone. So if you don't see me out at a meeting, you can call us, and we'll be happy to work with you. In fact, we're looking for those types of partnerships.
And I second that as well. I think that's one of the best ways to connect. We also encourage, depending on the interaction, social media. We've made partnerships over tweets, so we'll meet you where you are.
Yeah, well said.
Go ahead.
We already have a partnership with our collaborative, and if there's any collaboratives in the state of Florida, and if I can be a conduit to connect you with other AHECs in Florida, I'd be happy to do so.
Mm-hmm. Yeah, that's a really good point, because if you do go on our national website, you'll find the AHEC locations for every AHEC. So while, for example, in New York State, I'm located in Buffalo, there are 8 other centers in New York State that might be closer to you, and each one of them, I'm sure, would be looking forward to reaching out and speaking with you as well.
Absolutely, absolutely. And this is Rob again. One of the things that we're focusing on from a national perspective, and certainly is embodied in all the AHECs around the country, is being agile and responsive and making sure that we're engaged in community-based issues to the degree that every AHEC can be. But certainly that agility, nimbleness, and acting in many ways as a convener broker of activities too is pretty much at the core of nearly every AHEC. So I think for anyone on the phone who does make a call or reaches out, you'll find some great receptivity on the part of the local AHEC.
Okay, wonderful. Thank you so much. We're just about out of time here, so I'd just like to remind you about our resources on cancer control technical assistance. Please visit us at cancercontroltap.org and follow us on Twitter. Please know that you will receive an email today with the recording, and please, we ask you to fill out our evaluation survey after this. We want to know what we did well and also how we can improve and what we can do better in providing you technical assistance in the future. So a sincere thank you again to our speakers and to all of our attendees, and we hope you have a wonderful day.
Thank you.
Great. Thank you.
Bye-bye.
Bye-bye.